Wonderful. So thanks everybody for joining today. We're really glad to have you here, and we're very excited to have two speakers here today. So I'm going to take a minute and introduce our speakers. Oh, we have someone in the lobby here. I'll let them in. Awesome. Okay, so if you're just joining us, if you could take a minute and just write in the chat where you're joining us from, so your school, and then how many students are with you here today, that would be great. So today we're joined by Phil Kennedy and Pam Henderson. So the Horizon School of Radiography is being represented here today by Pam and Phil. So Pam is a program director of the Moncton campus, and Phil is the program director of the St. John campus. So radiological technology, or radiography, is an applied health profession that requires specialized instruction in the safe use of X-rays and to produce images of the body. So a career in radiological technology, or radiography, provides a balance between direct patient care and the use of advanced imaging technologies. The Horizon School of Radiography is partnered with the University of New Brunswick St. John's, UNBSJ, to offer a Bachelor of Health Sciences in Radiography. So I'm going to pass it over to Pam and Phil, who are going to present for us, and then we'll have some time for questions at the end. Thank you so much.
Thank you, Beth, very much. So I'm just going to tell you a little bit about how I came to this field. In high school, I graduated from Harrison Turville High School here in Moncton, and I went off to Dalhousie University to take my Bachelor of Science. And my final year of my science program, I thought, okay, now what am I going to do? So I started investigating healthcare fields, and I came across radiography. I'd never heard of it. And then I found out it was actually being taught in Moncton, where I was from. So I wish I had known earlier that I could have, gone into this program. But so that's why it's very important for us to get the word out that we are here and that we have a very exciting profession where you have a Bachelor of Health Science or a Bachelor of Health Science in Radiography, and you also have a profession at the end. So I've been teaching for 26 years. I've been a radiological technologist for 33 years. And I love my profession. And I think you'll see that as Phil and I go through our presentation, that we certainly enjoy what we do every day.
Yeah, so I'll tell a little bit about how I got involved in this. So back when I was just getting into university, I had plans on doing optometry at first, and so I went to UNB Fredericton to take my Bachelor of Science degree. I did my first year, and then I realized that I wanted to be able to get into the workforce sooner, and but I still wanted to be in healthcare. So I realized that my aunt was a radiological technologist, so I spoke with my aunt a little bit, and thought this was very interesting, and it proved to be true. I went through and I did the radiography program at St. Joseph's Hospital many years ago. And then in 2005, I decided I wanted to get into teaching, so I became the program director here at the St. John School of Radiological Technology, now the St. John campus of Horizon School. And like Pam, I enjoy this career. It's very interesting. There's never a boring day. Just looking at the image that you're seeing now on the screen shows you the difference. I may X-ray a hand on one patient and it's normal. And I'll X-ray another hand on another patient and you can see huge fractures like we see here. So anyway, that's a little bit about me, and I'll hand it back over to, actually, I'm going to carry it on from here, aren't I, Pam?
Yes, yeah, go ahead. I just kind of wanted to have this slide up while we were introducing ourselves, because I want you to get the impression that this is all about imaging. Now, we certainly, it's patient care as well, which we'll talk a little bit about after we talk about give you a little video, but we just want you to see that this is what we do every day. We take images, we see inside the body, and it's very exciting to do that and very interesting. So just kind of wanted to start you off by having a look at these. But yeah, go ahead, Phil.
Great. All right, thanks, Pam. So I'll tell you a little bit about medical imaging and Horizon Health Network at the moment. Currently in Horizon Health Network, there are about 15,000 employees overall. We have 19 medical imaging departments, all dispersed throughout about the lower two-third of the landmass of New Brunswick. We have 226 radiological technologists or radiographers working in the field in New Brunswick, 27 magnetic resonance imaging technologists, 17 nuclear medicine technologists, and we also have, I want to guess, probably about 20 or so, maybe 25 sonographers in the province as well. So right now, the vacancy rate in medical imaging is about 4.5%. I guess that roughly translates to 10 or 15 vacancies in medical imaging throughout the province at any given time. So, there is work available for sure. And, in these different fields that I've noted here. Excuse me. Just want to talk a little bit about where we would be performing our work. So, for the most part, we do our work in the in the medical imaging department doing general x-rays, and this would be performing some of those x-rays that Pam showed on that very first slide, the hand x-ray and the ankle x-rays. But also, really we x-ray any part of the body. It could be the abdomen, the head, the chest, any other part of the body. And then we do specialized imaging for other various parts of the body, such as, we can x-ray a joint, the shoulder joint. We can x-ray a knee joint. And sometimes we inject or introduce various contrast media to make things show up a little bit better. We can also be found doing CT or computed tomography or slice imaging of the body. We can also be doing fluoroscopy, which is really, if you want to think of it, it's like video of x-rays. So we're actually taking video of the x-ray itself, and we can see the insides of somebody's body and be able to see physiology as it's occurring. We also do mobile imaging. So if the patient can't come to us, then we can bring our equipment to them and do some rudimentary basic imaging. We also are found in the operating room, part of the surgical team. We can do mammography, which is specialized breast imaging. We do forensic radiography as well, which may be a surprise to some people, but we do post-mortem x-rays, during autopsies, which can be very interesting. We are often also found doing interventional radiology. Interventional radiology is just a little bit different. Rather than the focus being on diagnosis, it's more on treatment. So we provide imaging while a radiologist may be introducing catheters into specific parts of the body. Some of those areas are very delicate, and so the only way that you can really get a catheter in there successfully is with imaging assistance. We can also be found, something that's not on the slide here that I wanted to throw in there, but cardiac catheterization in the St. John Regional Hospital. We often do that as well.
We're just going to show you a recruitment video that actually Horizon had done for us. So we'll kind of get to see what some of the things that Phil has mentioned.
My name is Rebecca Snow. I'm the clinical instructor for the Horizon School of Radiography in St. John. I graduated from this same program back in 2015. In between that period of time, I worked all over the province. So I worked in Miramichi, Fredericton, Upper River Valley, and then now back here in my hometown of St. John, so it's nice to be back. I worked in lots of different areas, mostly Gen Rad, CT, and I was a scrub tech in interventional radiography as well. So I think that kind of diverse experience really lends itself well to my current role as an instructor. Gen Rad is general radiography, so that's kind of our bread and butter, taking x-rays. It also encompasses fluoroscopy, taking images in the OR, and portable x-rays as well.
My name is Raniel Hernandez, and I'm a student here at the Horizon School of Radiography here in St. John. So growing up, I've often been in a hospital setting as a patient, so that kind of inspired me to pursue a career in healthcare. I always had some sort of fascination with medical imaging. I found it so cool how we can look into the human body without opening it to see what's going on inside. And after one of my friends introduced me to the program in first year university, I just knew it was the perfect career path for me.
The degree through UNBSJ is a 4-year Bachelor of Health Sciences with a major in radiography. Now at that point you do your first year at UNBSJ, but then you have 2 choices. So if you choose the St. John campus, then you would do your kind of a back and forth between UNBSJ and the Horizon School of Radiography St. John, which is right next door. So they're very close together. The Moncton program, which is the same program, just the Moncton campus, it allows students to do what's called an articulated program. So they would do another full year at UNBSJ after their first year, and then they would go to Moncton for 2 years. So it's the same content, you end up with the same degree, but it just provides students with 2 different delivery options to suit their schedule and their lifestyle a bit better. Students gain the skills necessary to become entry to practice technologists. So on top of getting a bachelor's degree, which allows you to pursue other education if you wanted to, master's programs and things like that, the kind of hands-on technical skills that we're able to provide allow people to seamlessly enter the workforce after they graduate, which is really appealing to a lot of people.
Our schedule alternates between the classroom learning and the clinical rotations. So the clinical rotations really gives us the opportunity to solidify our skills and the knowledge that we learned in the classroom. So being confident in our abilities as a student will allow us to be competent as soon as we enter the workforce, as soon as we graduate.
So aside from our clinical component, which as I said is very hands-on, our classroom component also has a lot of hands-on aspects as well, since we realize that a lot of people come into this field because that's what they're looking for. We have a lot of physical learning aids, skeletons, physical x-rays. We do a lot of labs, a lot of simulations. So there's a lot of other things other than sitting there and listening to a lecture, which I think appeals to a lot of people.
The instructors in our program, they want us to succeed. We can tell they care about us as students, and without their hard work, their knowledge, and all the resources they provide to us, we wouldn't be able to progress as students. So I'm in my 3rd year of the program. Looking back at what I've learned so far and how much knowledge I've actually gained throughout the program, it's honestly mind-blowing. One of my biggest highlights so far has been being able to go to other places outside of the diagnostic imaging department. So places like the operating room to help with certain operations, and even forensic cases downstairs in the morgue.
There's so many opportunities right now within Horizon in all kinds of different capacities. So there's a lot of opportunities right now for casual work, and there's a lot of change happening in the workforce right now, which will lend itself well to there being a lot of permanent jobs in the near future. A career in radiography is so diverse, and it's such a nice balance between patient care and technology. It's constantly advancing. So it's a really great balance for people who are still looking for that patient care aspect to their job, but also want that technology.
The most rewarding part of this program really is just being able to learn how to help these people each and every day.
There, I hope you enjoyed that. That was just gives you a little picture of what we do on a daily basis. So I just have a few slides that will just kind of reiterate a little bit about what Becca was saying in the video. So we are partnered with UNB St. John. So we have 2 campuses, Moncton and St. John, so the Horizon School of Radiography. And basically the courses that you would take at UNBSJ would be general science and health science courses. So anatomy, chemistry, physics, healthcare, ethics, organizational behavior, your psychology courses, healthcare system. And then when you come to the radiography school, you're going to be taking anatomy again, specific skeletal anatomy, radiographic positioning, which is our job. We have to teach you how to position the patient properly in order to get the images that we need. Image analysis, which I'll talk a little bit about later. That's my favorite part of the job for sure. And then physics, the imaging apparatus, radiation safety. How do we keep the public safe and ourselves safe during these radiological exams? The 2 campuses, again, was kind of talked about in the video. So we have two different kind of streams of the program. So the integrated program is in St. John. So that means you go back and forth between the two campuses because they are side by side. And Moncton, where we're a little bit removed geographically, we have more articulated programs. So you do your first 2 years at UNBSJ, and then your years 3 and 4 are here in Moncton. And there is a course that you have to take from UNB in both years 3 and 4. So that's the basic setup of the two campuses. We do interview for these positions from UNBSJ, and we select 6 to 8 students per year. Right, I'm going to turn this over to Phil.
Yeah, that's and it's just to clarify too, it's 6 to 8 per campus as well. So it'd be a grand total of anywhere between 12 and 16. So
yeah, thank you, Phil.
I just want to talk a little bit about the attributes of a radiological technologist, because you need to either have or acquire a certain skill set in order to be able to do the work. So I'll go down through this list and talk about each one of these a little bit. So first of all, you need to be caring and empathetic. Caring, I think that anybody who gets into healthcare, you have to be able to care for other people. But the empathy part also is important. And, a lot of people talk about having sympathy for others. But what is sympathy versus empathy? Sympathy is more of an acknowledgement that you understand somebody is going through something that's difficult. Whereas empathy is when you're putting yourself in their shoes and you're feeling what they're going through to the extent that you're able. And what empathy does, when you train yourself to be empathetic, if you're not already empathetic, it enables you to tailor the care that you provide and be very specific for that patient so that you're giving them the best possible care for their situation. Radiological technologists also need to be organized. There are several different processes and procedures that we need to do with every patient, and they all need to be done sequentially. So we need to be able to make sure that we can do each process and kind of tick that box off and move on to the next process as we go. So we have to stay organized in order to do that work. And we also need to be able to make sure that we're keeping patient records organized and forwarding documents along with the patient and with the x-rays when that's required. Good communication skills are essential. We know that poor communication can actually kill in a hospital, which is not a great thing. As an example, we've got evidence and data that would suggest that about 83% of all adverse medical events that happen in a hospital are directly attributable to poor communication or a chain of poor communication. So we really do focus on good communicative ability, and that's partly why we do interviews at the application process to get a good feel for someone's natural communicative ability. Attention to detail is also very important. When we're assessing our images after we acquire them, we need to assess them for diagnostic quality. And so there are several different things that we need to assess. We need to assess, first of all, the positioning. We have to assess the level of detail that is present in the image. Is it appropriate for that type of image? We have to also assess the image contrast, the image blackness level or brightness level. And we're also looking for blurriness. We're looking for magnification of body structures. And of course, we're also looking for pathologies and making sure that we're demonstrating those pathologies to the appropriate degree. Radiological technologists also need to be good at problem solving, and in order to problem solve in the real world, and when we've got moving parts and things are happening in real time, we need to have good critical thinking skills. So what is critical thinking in terms of radiography? Critical thinking is when you can take the knowledge that you've learned and that you have and be able to adapt it and use it in real time to solve problems that present on a daily basis. We also need to have good physical and emotional stamina. So physical stamina in the sense that we are often having to move patients on and off of stretchers and on and off of radiographic tables or computed tomography support couches, various things like that, standing patients up, getting them into wheelchairs. So there is some degree of lifting and physical strength required. In addition to that, we also need to be emotionally strong or have emotional stamina. And the reason for that is, of course, that particularly when a patient arrives to us and it's a critical situation. And sometimes those cases can be emotional, and there can be emotion attached, especially if there are some family or friends who are with them. And so very often we need to be the strongest person emotionally in the room so that we can be there for everybody else. In addition to all those things, we need to have this willingness to learn because we're lifelong learners in this. We're very technology driven, meaning that as technology changes, and it does change rapidly, as everybody knows, the technology that we utilize to radiograph people is changes and improves. So we have to stay on top of that, and we have to continually adapt what we do so that we can utilize that new technology to its fullest.
Yeah, absolutely. Some of our job responsibilities, again, was talked a little bit about in the video, but I want this very first slide is probably the most important thing where it says care for patients. This, if I leave one thing with you, that's our number one priority and our goal is we care for our patients that we have with us during the image process and post process, the patient as well. So we answer their questions, we support them, we guide them, we listen, we take care of their needs. That is our priority, number one. And we can be imaging all kinds of different age groups. We image little babies or children or elderly patients. So we have to care for all patients. Positioning, so that's what we talk about with that radiographic positioning. So this is a big part of our education is how do we position the patient? How do we position them properly? Because our images, what we produce as technologists, are going to physicians, are going to radiologists that read and diagnose these patients. So our images have to be good. So how do we position that patient to get that specific bone or specific pathology properly so that that patient gets properly diagnosed and treated? Radiation protection. So we do use ionizing radiation. So we have to protect our patients. We protect the public. We have to protect ourselves. So that again is a big part of our educational system is how do you do that? What are the tools that we have on hand to support that? We operate, as Phyllis said, we operate very complex radiographic equipment, and that technology is constantly evolving, which is really an exciting part of what we do every day is we get to use these pieces of equipment. What you're seeing here in this picture is actually what we call a C-arm that we use in the OR. And that's live imaging, fluoroscopy, as Phyllis mentioned, that we can do during surgical cases. So it's usually quite an exciting place for us to work. Educating patients as well. Sometimes some of our procedures are really long, lengthy. They involved administration of contrast media. So we have to do pre-procedural checks and questionnaires. We have to educate during and post procedures, make sure the patient understands throughout the whole examination what we're doing and why we're doing these things. And if there's any type of post-care that patient has to do when they leave us as well. This is my favorite part of my job too, is caring for the patients and then evaluating the images. So you instantly get to see how good you did. Is it good? We have to know what we're looking at. We have to know our anatomy really well. And we have to know how we can then maybe reposition the patient to get that image that we need. So again, really huge part of our educational system here is that evaluation and image analysis piece as well. And Phil's going to talk about some of the modalities, which he's mentioned before, but we'll just give you a little visual of that.
Yeah, so I'll just start out with the idea that I know that many people in the public have there's this common misconception that we somehow have this magic camera that we point at patients and it's auto focus, auto whatever, and we just kind of take a picture and magically there's an X-ray. But that's not how it works at all. We have to basically shape beam parameters, X-ray beam parameters, and tailor the X-ray beam for the body part. And if you want to think of it this way, you can kind of think of an X-ray as a shadow image of the internal structures of the body. It's like we're shining invisible light through the patient's body and casting a shadow of their internal structures on the other side on the imaging plate. And so we have to adjust beam parameters like the beam intensity and the beam penetrating power in order to get just the right image as the beam passes through the patient's body. General radiography is the process where we're doing just that. You can see in the upper left corner where this technologist is taking a picture of this gentleman's shoulder. The X-ray beam is passing through the patient's shoulder, and the shadow image of the shoulder is getting cast onto the image receptor behind the patient. The result is what you see on the right, I'm sorry, and that is an X-ray of the patient's shoulder. And sometimes, you hear, especially in high school or in middle school, students who are involved in sports might have a fracture of their collarbone. And you can see the collarbone right there at the very top portions, that bone that's running horizontally. So you can see the humerus, and you can see the collarbone. You can also see the scapula or the shoulder blade, commonly known as the shoulder blade. Next slide. Computed tomography is another imaging modality. What do we mean by a modality? It's a whole different use of X-ray imaging to give us a different appreciation or a different angle, I suppose, on imaging a particular structure. So the best way I could describe computed tomography would be to think of slicing up a loaf of bread. Okay, except that instead of physically slicing up that loaf of bread, we are slicing up the patient virtually with slice imaging. So it's like taking slices of the patient and then X-raying each slice and presenting each slice on our monitor. So that would be a very rough way of describing it. It's actually, it's of course much more complicated, but that's a really good starting point. And in the image at the upper right here, you can see that this is basically a cross section through the patient's abdomen. That white structure at the very bottom is the patient's spine. And those two structures lateral to that, those whitish looking structures, are contrast filled kidneys. Then you can see there's a large blob at the upper left portion. And I think, yeah, there's Pam's cursor, and that's the liver.
Oh, okay. The liver. Oh, yeah. There we
Liver,
are.
yep. And then on the other side, sorry, at the left of the screen, not to the left of the patient. That's something else we always have to keep straight as well, right? Now Pam's just pointing at the spleen right there. And then there's other structures in there. That's bowel. There's some gas in there, and there's some vasculature as well, some blood vessels. And at the very back, you can also see some muscle. And then just lateral to the spine, you can see what we call the psoas muscle. All right. Next,
so we say you have to know your anatomy. This is what we need for sure.
Anatomy is definitely key.
Sorry. I think I put one here. Sorry. I went by one still. Sorry about that.
No worries. That's fine. So as we mentioned, fluoroscopy is basically video of internal structures. So I'll start off just by directing you to that image at the middle of the screen. It looks like of an infant you can see that their esophagus is highlighted in white, and you can also see the stomach down there that's also got some white in it. That white is actually contrast media. So during this procedure, we would have gotten this baby to drink, probably through a straw or something like that, some barium sulfate, maybe mixed with water or juice. And the barium coats the lining of the esophagus and the lining of the stomach. And while the baby is drinking, we can see them swallow. We can watch the esophagus moving and squeezing the food or water down into the stomach. And in this case here, where the arrow is in the middle of the screen, you can see that this child has a stricture of their esophagus, and that is giving them trouble. They're probably having a lot of projectile vomiting and probably not able to keep their food down. So that would be something that could be fixed through interventional radiology, where they might be able to go in and dilate the esophagus a little bit. So yeah, fluoroscopy. We do, we can do moving X-ray images of pretty much any region of the anatomy. The procedure on the left there, the right of the screen, is a more complex procedure known as an ERCP. You want me to say it, Pam? Endoscopic retrograde cholangiopancreatogram. So That one's a little bit more elaborate, where we have to introduce a catheter retrograde down through the esophagus and into some of the hepatic ducts, and then we can also inject contrast media, and we can see some structures down in there. Mobile radiography. If the patient can't come to us, and if they happen to be an inpatient, then we can often take our equipment to them, or a limited version of equipment to them. So you can see at the far left of your screen, you can see two technologists with a mobile X-ray machine, and then in the middle, you can see that they've already set the equipment up over top of the patient. And like any X-ray, they're going to have the X-ray tube up above. Then the X-ray beam goes through the patient, and then there will be an image receptor below the patient to receive the image. And then same thing at the far right, you can see that another X-ray is being done as well. So yeah, we can take our equipment. If the patient can't come see us, we can take our equipment to them, and we can at least get basic images.
And what's really with that technological advancement, what you're seeing here, especially in trauma situations or in your surgical intensive care, for instance, we're seeing those images right away with digital imaging. Mm-hmm. So that has been huge for us, our working conditions, and for patient care as well.
Yeah, the speed with which we can do our work, because we used to have to in the days of film, we used to have to take our images down to a photo lab basically and process them, and then so there was a delay of 10-15 minutes before we could see the images. Now it's just like that, we can see those images.
Yeah, so the patient right away.
Yeah. As we mentioned earlier, we do work in the operating room. We're part of the surgical team. You can see that there's members of the surgical team here standing around this piece of X-ray equipment known as a C-arm. We use this quite extensively in the operating room because you can see that C shape of that equipment. That allows us to move both the X-ray source and the image receptor over and under the patient at the same time, keeping the alignment perfectly. So not only can we do still imaging with that, but we use that to do fluoroscopy in the operating room, which greatly assists surgeons when they're doing various procedures. The X-ray that you can see to the right of the screen is a orthopedic procedure known as a hip pinning, where someone had a fracture in their hip, and the surgeon put some screws in there to stabilize the fracture until it heals, and perhaps leave those pins in indefinitely to help add strength to the fractured area. Mammography is using X-rays for specialized breast imaging. And as you know, breast cancer is something that we're always concerned about. And if we can detect it early, then it helps us to be able to intervene early. And, the rate of cure when we can detect breast cancer early is extremely high. So if you look at the image to the far left of your screen, you can see that the equipment does look a little different than some of the other X-ray equipment you've seen so far. And that's because it's specialized for breast imaging. It has to be, first of all, you have to be able to position it while the patient is standing up. You also have to be able to compress the breast tissue so that we can see the structures a little bit better. And the equipment also has to be capable of specialized beam parameters, because we're X-raying soft tissue, and we also need to be able to capture that tissue in exceptionally high detail, which brings me to the image. If you have a look at that image at the right, there are some little tiny white specks that you might be able to see. And just want to get my phone turned off there. There's some little white specks that you can see throughout. Those white specks are what we call microcalcifications, and those actually are early indications of ductal breast carcinoma. So if we can't see those specks, then we can't make an early diagnosis of ductal carcinoma, and that's why that very high resolution imaging is required. As we talked about before, you can find us in the morgue doing forensic radiography as part of autopsies, and sometimes the work that we do can replace an autopsy. It depends on the circumstances. And so, if you like those programs like CSI and all that, we do all that kind of work. If you want to, just have a look at the upper the image in the upper left-hand corner, and you can see there's a little white dot, and you can probably assume, maybe, but that is actually a bullet. So someone was shot, and that was the cause of death. So that's documented, and that's mostly why we go down to the morgue. Even if the pathologist knows the cause of death, we'll often go down to document the cause of death in X-ray format. And it's something that we see as kind of a sacred duty. It's the very last X-ray exam that a patient's ever going to receive before their family puts them to rest. And so it's something that we take very, very seriously and solemnly. If you look at the image to the left, sorry, to the right of the screen. I keep getting this backwards. I'm trying to think of the way people are viewing this. That looks to me like this person succumbed to a head trauma. And you can see that that looks to me like a fracture. That does not look to me like a normal location for a suture. But Pam can maybe draw a line through that black line right down the middle. So it looks like maybe they succumbed to a head injury, and it's been documented. Interventional radiology. This is where, when you look at that image to the far left, it kind of reminds you of an operating room. And that's because it is basically an operating room. It's a sterile field that's maintained. But the exception is that the imaging technology and equipment that is used there is very, very specialized. You would not find this in a typical operating room. And so with interventional radiology, the focus is less on diagnosing sometimes. I mean, there are some things that we do to make a diagnosis, but very often the focus is on intervening or providing a therapeutic solution to whatever the problem the patient may have. So, for example, many patients come in with, stenosed cardiac vessels, and that may be the reason why they had a heart attack, for example. With interventional radiology, the radiologist can use under image guidance, can assist or can insert a catheter through the femoral artery up into the cardiac vessels, and then use a balloon at the end of the catheter to distend the dilated arteries so the blood can flow again. And it's like an instantaneous feeling of relief with these patients. All of a sudden, they feel 100%. If you look at the image to the right, that's another type of an interventional procedure that would be known as a cardiac angiogram, or not cardiac, a carotid angiogram. And this is where a catheter is inserted through the carotid arteries, and then radiographic contrast media is injected to highlight the vessels in the brain. And this can help to diagnose things like stroke. For example, we can see if there's, a bleed or maybe an aneurysm, and we can see if there's things pushing as well on blood vessels, which might indicate a tumor.
I'm just looking at the time, Phil, too. I know we have just till 12:15, Beth, so we'll just, I just want some time in case someone has some questions too, so that's all.
Right, yeah. Sorry, people
No,
long-winded there.
that's okay.
It's
okay.
fascinating, though.
Yeah, no, it's good. I just noticed the time, so I just want to make sure in case someone has questions, but anyway, that's good. So lifelong learning, yeah, we had mentioned that before, how this is just an example. This is new equipment that we just received. Well, it's been a few years now, but we had to learn how to use this equipment in the OR. So it's basically like a CT machine that we're as a mobile into the OR theaters. So, and they have guidance in order to go to in the back or in a tumor or things like that. So this is what we mean by lifelong learning. So things will continue to advance in our field, and we're going to have to stay up on top of all of that.
So this image here is just you can see that there's an image of someone's neck, and then on the other side, obviously a fractured leg. The one on the image of the neck, it may not be so obvious, but there is a fracture there and a displacement. That's pretty serious because you can see that there is one vertebra that stepped very far forward on the next vertebra down, and the spinal cord runs right down the middle. So if you're pushing one vertebra forward off of the other, you can imagine there's this shearing effect that can cut, even sever the spinal cord in half, and that is what can either cause someone's death or it could result in quadriplegia, paraplegia down lower. This is a, CT exam of someone's abdomen. So one thing that we can do with computed tomography is, even though we acquire the slice images as if you're slicing up a loaf of bread, once we collect all that data, we can reconstruct the data in any plane that we wish. So that's what's happened here. We've reconstructed the data so that it's looking more coronally through the patient, and we can see we can get a different kind of an appreciation of the anatomy, just at a little different angle and view. This is a image of a heart, I would say, as the result probably of a cardiac perfusion scan where contrast media was introduced into the heart and the blood vessels were highlighted. You can see all those vessels kind of coming off. Another thing that we can do with CT that's demonstrated here is we can apply color shading to make the various structures almost appear as they would in real life. And that can give a physician a better appreciation of where structures are located and what certain structures are comprised of. And it can be very useful for surgical planning, as an example. Last but not least, when we look at imaging, we're currently really starting to get into artificial intelligence to assist with diagnosis. So we currently are using computer-assisted diagnosis, which is CAD for short. But what's happening in this image here, you can see that this is to the left of the screen, the plain radiograph that you're looking at, is actually demonstrating a pathology. If you look at the haziness of the lungs down below, and then you can see that the artificial intelligence is highlighting those areas. And the artificial intelligence is just accessing a huge database of known problematic chest x-rays, taking that information and then superimposing it on top of the x-rays that we do, and then offering a potential diagnosis based on what you might call the evidence that's located in the database. So it's often used by radiologists as a second read or a second set of eyes. Very, very useful.
Yeah, so we'll just finish off with some of the job opportunities that New Brunswick has. So here's our salary. So it does range. It depends on what job that you do have. So between 65 and 100. 100 would be more your supervisory roles. Just know technologists, radiological technologists work in the hospital. They're on duty 24 hours a day, 365 days a year. And sometimes some technologists are actually on call, especially the interventional radiology that Phil was speaking of earlier. They do a lot of call because those particular patients are acute and traumatic. So that can happen at any time of the day. Where we work outside of hospitals, you could work in clinics, you could work in management. Some of our students have gone on and worked with vendors, so with GE or Philips, and they become application specialists because they have the knowledge and they can share that knowledge to other technologists across the country. Into education, as Phil and myself, our National Association MRTs work for, quality assurance technologists, so that they are there to make sure that everything is working properly in our departments and our images are of good diagnostic quality. Radiation safety officers, you can do that as a provincial appointment, so that again you're monitoring the radiation safety for the public. MRI technologist is a different modality than radiological technologist, and it does require some additional education after entry to practice. As a radiological technologist, or as you come through our programs, you do write a national certification exam, and what that does, if passed, of course, you can work anywhere in Canada. So that's really helpful as well, even though we want you to stay in Horizon and work for us. And that completes our presentation. So I don't know if there's any questions that you might have about the program structure or about our profession, but we certainly are willing to answer. And if you do have some later on, we could always receive those probably from Beth as well, if you think of things after our presentation.
Thank you so much. That really was fascinating. Wow. I can't wait to share this with more classes. We'll see if there's any questions in the chat here. Not yet, and maybe while we're waiting. So feel free to type your questions in the chat, you guys, if you have any. This is your chance. Maybe if any of you have advice for high school students, I know you did such a good job describing the skills that are important for this role. Any advice you have about how students could go about developing those skills? Oh, and then Vanessa has a question as well. That's great, Vanessa. Toss it right in the chat if you don't mind.
I think from just my perspective, if you're interested in healthcare, just investigate all the healthcare possibilities that are out there. If you're an empathetic person, a caring person, you want to help others, you want to, work with technology, you want to continue to learn and know that you can work in different capacities within the hospital, just investigate as many different fields as you can. I wish I had done that when I was in high school. I was kind of focused on one thing and I didn't look outside of that. And sometimes life doesn't point you in that direction you think you're going to go. So that would be my biggest advice, is just keep your mind open to other possibilities. Don't think that this is the only thing that you want to do in your life.
Yeah, I agree. And one thing I would say about radiological technology is that if you're a student and you're thinking about getting into nursing or medicine, but you also have this really extreme interest in technology. This is like a perfect blend of being able to provide patient care and to use some really, really expensive and fancy technology. So I think that I think is something that a lot of people, it might appeal to them.
For sure.
That's really helpful. Thank you. Maybe what I'll do is I'll end the recording, and then I think somebody does have a question that they want to ask, so maybe we'll stick around for a minute, but it's easier after we stop the recording here. There we go.